I've got a very interesting case where a 31-year-old patient who is a thalassemic major and who requires blood transfusion almost every couple of weeks presented to me with a severe pain in the hip since 3 months, gradually getting worse. And now he comes to a stage where he is absolutely unable to bear weight on it. He was operated for a supracondylar fracture on the same side 4 years ago. And another important part is he had history of multiple infections in the past, namely chest infection, urinary tract infection, and on examination, he had extremely painful restricted range of movement. So obviously first, depending on history and examination, was septic hip, which is a primary septic hip, knowing that he's prone to infections. We aspirated his hip in theater, and we found pus, which was not a surprise. We grew pseudomonas, so we consulted him and operated by my arthroscopic colleague by extensive arthroscopic hip debridement.
Okay, let's stop you right there. We haven't seen the x-rays yet, but you know, this is a total joint course. So I'm going to obviously get a little on your case for doing hip arthroscopy to wash out, you know, this hip, when I think you probably should have opened them up and put a spacer in and done a real debridement. Who on the podium wants to do arthroscopy? Raise your hand. See, you didn't get one person to agree with you.
Well, we don't know the rest of the story yet, but
let's go.
But just, I was just going to say, I was going to agree with you, Amar, because most of these patients sickle cell are going to have avascular necrosis, right? So you've got dead bone there. So unless you get that out, at least the big chunk of the head out, you know, getting rid of the infection is harder. I'm not saying you can't do it, but I'd just be less confident that you got rid of it.
Let me just add on to that. I mean, that option was given to him, but because he was 31 and he flatly said that, look, I don't want a total hip replacement. Can you just save this hip? And we said absolutely no chance, but we'll give it a try. So it was patient who forced us, and it's a private hospital, so we can't say no.
So you have x-rays and more?
Yeah, so I'm coming to that. So he was all right because he was treated with IV antibiotics for 8 weeks, and he disappeared, and his pain subsided subsequently. He presented 1.5 years after this arthroscopic surgery, and this time again he had a severe pain in the hip. He was limping. He was 1 centimeter short with just a jog of movement. Now this time his inflammatory markers were absolutely normal, and his hip aspirate was negative. This was the hip picture. We are talking on the left side.
What did his hip look like, though, 2 years ago?
It was looking much better. I'm afraid I don't have the x-rays, but it was looking something like on the right side, but the head was much more preserved than what it was. Now, obviously, you are looking at I mean, this was the AP and this is the lateral view. So this was a post-septic hip, fibrous ankylosis kind of hip. And mind you, we aspirated this hip and there was absolutely no signs of infection locally as well as clinically, and radiologically it was a fibrous ankylosed hip.
So here's a question for you. What do you think the value is of an aspiration in this setting?
I'll come to that because we gave him 3 options after that. We said that, look, you are very prone to infections, 1. Secondly, we already knew that there was an infection 1.5 years ago, and I'm just not happy doing a total hip replacement. And he was just forcing that, look, I don't want arthrodesis, neither do I want excision arthroplasty.
Okay. We got it. Thorsten, you got a comment?
I mean, that is the reason we went ahead, just to make sure whether we can go ahead and do a total hip replacement. We also have taken a couple of other opinions, and all of them said that if at all patient want, we can go ahead with a total hip replacement.
So I would say don't rely on an aspiration and fused hip and collotic hip. So I don't know how you technically make it. I can't do it. I can't get out in a native hip and collotic hip to get fluid out. And the normal ESR or CRP doesn't exclude the infection. So especially in this patient, I would go for an open biopsy, to be honest, because he is 21. You have not so many shots, and I would recommend in those cases an open biopsy because it's quite suspicious, especially if he had a history of Pseudomonas.
And nowadays, sometimes we'll do a PET scan stuff because the PETs can pick up infection in these cases. I don't know if that's available in India, but
It's another great.
Anybody want to add anything else?
We did a bone scan, and bone scan was not showing any increased uptake on that area. Of course, PET scan is much better.
What kind of bone scan was it? Indium labeled? WBC?
Yes, yes,
And it was negative?
yes.
That helps. Yeah, that's another option.
Okay, so what happened?
So, and anything panel wants to, I mean,
I would just say that I don't think that this patient's going to be a good arthrodesis candidate, right? Because arthrodesis is, well, first of all, there's a lot of reasons, but particularly somebody that's at risk for bilateral disease, you're probably not going to do an arthrodesis, right?
mind you, he's just 31-year-old.
And then the rest of the femur is not seen again, just like a point which Amar made some time back. Whatever femur we see is very bad.
Actually, that's what I'm coming to, because as I mentioned in the history, he had a supracondylar fracture, which I plated 4 years ago, and I'm really sorry I didn't have the X-ray, because it has got a direct consequences to what I did. So I planned for a uncemented total hip replacement, obviously because he was 31. And this was the head which I removed, obviously completely destroyed and gone. And this is what I did. Now, there will be a lot of eyebrows raised. Why did I put a cemented stem? The whole reason is once I started brushing the femur, the whole calcar was opening up and there was absolutely zero rotational stability. And the other point is, if you can now see in the X-rays that there is a plate which is coming up. So if I would have put an uncemented stem, it would have just ended centimeter proximal to this plate, and that would have act as a severe stress riser, leading to fracture. So, and again, the acetabular side was extremely poor. So this is a Gripsum cuff which I used, fixed it with 3 screws, and used his own bone graft and grafted it. To my surprise, the samples which we sent from the acetabular side, a couple of weeks later came as tuberculosis positive. So post-operatively, I gave him anti-tuberculosis treatment for almost 9 months. This was the lateral. And if you can appreciate, I have put the cement right up to the first screw. And this is now 7 years, and he is holding on. Any comments, please?
Well, don't argue with good success. The other advantage of the cement, which you didn't mention, was you hopefully delivered local antibiotics.
Yes, and yeah, good point. I put vancomycin along with the gentamicin, which was already there. So the cement has got 2 sets of antibiotics.
So it's really then.
What really scared me was the tuberculosis secondary infection, which I found. But fortunately, now it's 7 years down the line, and he's doing very well. In fact,
by having all that antibiotic in your cement, you can make the argument you've made a spacer. You know, a well-functioning spacer.
Yeah, so a couple of lessons I learned from this is always keep a cemented option, especially in door 3, which was the case, because sometimes you'll be foxed. Though he's 31, no way I could have put uncemented stem. And the other thing which helped was the plate down there. If I wouldn't have put a cement in, I would have created a stress riser, which would have caused a fracture. Now the proof of the pudding is eating. He just presented to me 3 months ago with knee fracture. Now I know it's not a knee meeting, but this is what his knee X-rays are, and this is what I did. Just a passing comment. And this is now 3 months down the line, sir.
Looks good.
Thank you.